and its management. So, as a way of introduction, labor is a series of events that take place in the genital organs in an effort to expel the viable
Sorry,
products of conception. Can you hear
sorry.
me?
Please share your screen. Let's see your video so to become recording this stuff.
Okay. Sorry.
As in put on your camera on so they can see you. Okay, correct.
Yeah. So, are you still seeing me? Okay. So, labor is a series of events that take place and starts with painful, progressive uterine contractions that eventually leads to the expulsion of the fetus. And there are a lot of theories, that has been linked to the start of labor, starting from the contribution from the fetal-maternal unit, the placental unit, and even the fetal adrenal gland. And one of those hormones that have been looked into is cortisol. And there are a lot of agents that has been touted as being responsible for the onset of labor. But I'm not going to bore you with all these ones because for the level of exams you're going in for, you might not be tested on some of those things. So labor, has different stages. I'm going to look at the different stages and then management for each of them. So I'm going to start off from the first stage of labor. And the first stage of labor is simply divided into two parts. You have the latent phase and then the active phase. For the latent phase of labor is labor that is yet to reach a cervical dilatation that is considered to be active phase. And previously, this was put at 4 centimeters. So, but in recent times, after the 2017 document by the WHO, active phase have now been moved to 5 centimeters. So, usually, any patient that presents in the latent phase of labor is usually monitored. She would less likely in our own environment where there is always no space, will not be admitted into the ward, and then she's reviewed um, periodically. The first one should be around 4 hours, but subsequently about 8 hours. If by the 8th hour the patient has not progressed to active phase, she's said to be in prolonged latent phase. Now, if also by the 24 hours she has not, at the 8th hour, when she's in prolonged latent phase, there are different things that could be done. If she's still contracting, we can decide to monitor the patient as long as the maternal and fetal vital signs are stable. We can monitor the patient and keep monitoring. However, if by the 24th hour from when she was admitted in latent phase, she has not progressed into active phase of labor, and then the patient can, at this point, be termed as having a false labor. Now, false labor could be two types. There is the contractile false labor, and then there is the non-contractile false labor. So if the patient is having a non-contractile false labor, she is still far from term. Such a patient can be, discharged home to be seen subsequently in an antenatal clinic. Now, if a patient is having a contractile false labor, occasionally she might not be discharged home, might just be monitored in the hospital for a while until she goes into active phase of labor. Now, one of the other things that can be done from the level of the prolonged latent phase is that the prolonged latent phase can be terminated by the use of oxytocin, especially in the patient that is no longer contracting, probably has passed EDD already. So the patient has a need for immediate delivery. So misoprostol, 25 micrograms to 50 micrograms could be passed to terminate this latent phase. So that is it about latent phase. Now, in the other aspect of the first stage of labor, that is the active phase of labor, which starts around 4 centimeters of dilatation. However, as I said, in recent times, 5 cm is now being advocated by the WHO. So, in active phase of labor, there are different management methods. Now, there is a passive way of managing active phase, and then there is an active way of managing active phase of labor. So usually, when these patients present, they are usually reviewed, including their antenatal records are also reviewed, and then this patient usually is admitted. Now, once this patient is admitted in, there is the use of a pantograph. Although also in recent times, with the recommendation of the use of 5 cm, WHO has also provided another tool to use in labor, which is called the labor care guide. And well, I'm not sure yet if they've started using it for your own exams, but I'm sure in the next, if it has not started, within the next year or the next 2 years, it might start showing up in your exams, because the Ministry of Health has just recently, the late last year, adopted how this labor care guide can be adapted to our own use in Nigeria. So I'm sure in a very short time it's going to start appearing in your exam. But currently, as I know, what's appearing in your exam is the pantograph. And the most important thing about pantograph is usually how what they like to ask is how to interpret a pantograph, which we would also go through at a different lecture, and then the periods at which each of the activities is carried out in labor. So I'm going to be looking at both the maternal and then the fetal components of this pantograph. So for the maternal components of this pantograph, it includes the maternal biodata and identifying factors. You want to capture everything on this pantograph, especially in most pantograph is usually on the first page of the pantograph, where they capture these factors include the woman's name, whether she has booked on or for antenatal care or not, and then other factors that is captured is how many her parity, her gravidity, how many children are alive, her past obstetric history, and then the history of the index pregnancy. Also, a brief history of this labor is also usually captured at the front page of the photograph. And then this includes when she went into labor, when the labor started, if she has started seeing liquor already, and then other things would be the examination features at the presentation, which would include a general exam and then the obstetric examination for this patient, as well as the vaginal examination for the patient. So all these are usually what is captured in most photographs on the front page of the photograph. And then also on that front page, part of the examination is usually the clinical pelvimetry that is usually done for this patient. This is to tell us whether the pelvis is adequate or not. Depending on if this is going to be part of the exam, I'll also discuss the clinical pelvimetry at a different forum. And then on the flip side of the photograph, is usually the portion, detailing the vaginal examination for this patient and how many times this should be done. It involves the cervicogram and then the fetal heart rate monitoring, the amniotic fluid monitoring, and then other parameters like the caput and molding for this patient. So for the fetal heart rate monitoring for patients in active phase of labor, usually in the first stage of in the active phase of labor, these patients are monitored 15 to 30 minutes. In fact, usually it's 15 minutes. It's 15 minutes, 30 minutes for a patient that is not that is low risk, and then 15 minutes for a patient that is high risk. Or then high risk patients include patients that have medical conditions, a patient that is having a vaginal delivery after cesarean section, a patient that is being on trial of labor, and then some other patients, a patient on augmentation of labor as well is also classified as a high risk patient in the first stage of labor. and this one should be monitored at least 15 minutes, every 15 minutes for the fetal heart rate. And the normal fetal heart rate for being used in Nigeria is currently 120 to 160 beats per minute. However, with the introduction of the labor care guide, as I've mentioned earlier, the normal fetal heart rate has been shifted to 110 to 160 beats per minute. Okay, so fetal heart rate that are less than 110 or 120 is usually considered as fetal bradycardia, and this is usually an indication for immediate delivery. Even fetal heart rates, usually the way fetal distress goes is starts from the tachycardia and then goes to bradycardia. So usually once fetal tachycardia is noted, um, the the plan is usually to try to resuscitate to see if the fetal heart will pick up. And some of those things we do in fetal to we do are to improve the fetal maternal circulation as well as improve the oxygen carrying capacity of the blood. So some of those things would include giving the mother intranasal oxygen, and then giving IV fluid, as well as placing the patient in the left lateral position. All these are aimed to improve the flow through the fetal maternal circulation, and as well as increasing the oxygen carrying capacity in this patient. So also one of the other things that I also looked at in the flip side of the pathograph is the area where you want to look at the types of the liquor. Now, the liquor is the fluid that surrounds the baby, and in some instances, once in areas where active management of the first stage of labor is done, the early amniotomy is usually advised. Usually, once a woman is admitted, an amniotomy is done, usually with an amnio hook, or on the other flip side, you can use a coccus to, break break the membranes, and then allow the water. A control release of the water is allowed. And then now the color of that fluid is usually also on the flip side of the photograph. It could be clear, it could be blood stained, you would indicate as B. For clear, you indicate C. For blood stain, would be indicated as B. And then if the amniotomy is not yet done, you can indicate I, which means intact membranes. And then if there is meconium stain, you could also indicate M for meconium stains. So each of them tells a story for the patient. And there are a group of patients that even in places where active management of the first stage of labor is done are not candidates for early amniotomy. And those include patients with conditions that can be transmitted from the mother to the baby, including things like retroviral disease, and even patients with hepatitis are usually left till later on in the labor before amniotomy is done for these patients. And then the main part of the flip side of the pathogram is the cervicogram. Now, the cervicogram, the monitoring of the amniotic fluid is done together with the monitoring of the cervicogram, which is the vaginal examination for patients in first stage of labor. And for ADN, it is done every 4 hours. So for the cervicogram, it just looks at the dilation of the cervix, dilatation of the cervix, and then the descent of the presenting part. Now, I say descent of the presenting part because it could be the head, it could be the buttocks, could be, and those are the only two parts that can be allowed to go into labor. Any other presentation would usually be delivered by cesarean section. And then this is done every 4 hours. And then the pathograph is actually called a referral tool. So any patient that deviates from the normal initially used to be that the woman should dilate at 1 cm per hour. But with the new WHO care guide, it is believed that every woman does not dilate at the same time. And so more allowances is given to these patients to dilate at their own time. But what is currently done before the WHO labor care guide takes over is that a woman should have at least 1 cm per hour dilatation of the cervix. And a descent should be likewise be the same. So this first stage of labor is the period between 4 or 5 cm dilatation to full cervical dilatation, which is 10 cm. And this patient is monitored, as I said. Vaginal examination is 4 hourly for this patient. And then the next column would be the I'm sorry, I'm going from vaginal then to, but it's usually the way the pathograph is arranged. So the next point here would be the abdominal examination. For the abdominal examination for this patient, for the that is what is really of interest is usually the fetal heart rate, which I've mentioned earlier, listing using either a pinard stethoscope or a sonicate or a Doppler device. Or in some cases, some patients can have continuous fetal heart rate monitoring using a cardiotogography. So the what is of interest in the vaginal exam here is the abdominal exam is the contractions, how many contractions the patient is having. And for the contraction, we are interested in the strength of the contraction, the duration of the contraction, and how many contractions is happening in 10 minutes. Now, this is important because for a patient that is not progressing well and is having problems with the contraction, probably a normal contraction should be 3 to 5 contractions in 10 minutes, and a normal contraction should last at least 45 to 60 seconds and should be at least moderate or strong. Hello, I hope I'm still being heard. Hello, I hope I'm still being heard.
Yes, doctor.
Yes.
Okay, so as I said, the normal contraction should last at least 45 seconds to 60 seconds and should be within the category of moderate or strong. So anything less than that is usually termed inadequate uterine contractions. And if the labor is not progressing as expected, this patient is a candidate for augmentation of labor. The augmentation of labor is just meant to improve the contractions of this patient, either the strength or the frequency, as well as the duration of the contraction. So usually augmentation of labor is done with an oxytocin, in this case oxytocin, and the protocol is different in different places, but what is used for low risk patients is about five international units of oxytocin, usually put in about 500 mils of normal saline or dextrose water to run slowly at a certain rate. So the rate now depends on the center, but the common rates being used are 4. Then this is escalated to 8, 16, 32, 64. The other rate that is being used is 5 drops to 10 drops, 20 drops, and then 40 drops. So depending on whatever is that's how augmentation is to be done. Then for those patients that are high risk patients, for instance, patient with one previous cesarean section scar who are in labor, or patients that have delivered more than 5 times or more, as the grand multiparous women. These women are those that are at high risk, that are labeled as high risk in terms of augmentation. So the what is used in this patient is about 2.5 international units of oxytocin, and then the rate of escalation is the same. Now the timing of escalation is usually 30 minutes for patients that are low risk. However, for patients that are high risk, at least 45 minutes and above. So the other things to look at is the fluid, the medications that are used in this patient, which are also captured usually in the pathograph, in the flip side of the pathograph, and whatever is used is usually charted on those pathograph. And then finally, the last part of the pathograph usually contains the maternal vital signs, which includes the blood pressure, temperature, as well as the pulse rate of the mother of the woman. And these are usually done ideally should be done every hour. But some authorities also look at doing it every 2 hours. But if you see every hour in your exam, I think that should be the correct thing that you should pick. So these are done, monitored like that. And then one of the things that I also missed out in this clip side of the photograph is the fact that the quantity of the urine that a woman makes should be monitored hourly. And then also part of that monitoring should include the level of the acetone as well as the protein in the urine of that patient. So that also should be monitored every hour. There are some patients that require additional monitoring in the active phase of labor, and these patients include patients with cardiac disorders in pregnancy, and then sickle cell disease patients, as well as patients with um, gestational diabetes or diabetes in pregnancy. So these women require other additional items in labor. For instance, for the woman with cardiac disease in pregnancy, you want to be monitoring her in a propped up position, and then she should be on intranasal oxygen in addition to other things, as well as for patients with sickle cell, this patient PCV is monitored every hour in labor. I'm sorry, that's just the problem. I'm using my phone as I said earlier, so I just got a call. So so as I was talking about the patient, the cardiac disease patient in labor, I said this patient should be on intranasal oxygen. So for a sickle cell disease patient in labor, the other things I said, PCV should be hourly. And then in addition to other things, this patient's spleen and liver size should be monitored hourly. And then this patient should also be on intranasal oxygen as well as IV fluid in labor. For patients with diabetes, this patient should also have monitoring of the blood sugar every hour. And then depending on what the blood sugar is, there is a scale for monitoring for them having IV fluid or IV dextrose together with insulin, depending on what the blood sugar is. So these patients are monitored until they are in the until they are fully dilated, at which point they've crossed over from the first stage of labor. Now, as I said earlier, if despite all this, patient is not moving well, even despite augmentation, or we start having problems with fetal distress, those are all indications for either referral of the patient to a higher center or delivery by other routes, especially the abdominal routes. So once this patient has gone into second stage of labor, second stage of labor begins where a woman is fully dilated and then ends after the delivery of the baby. Now, second stage has two distinct phases. The first is what is called the pelvic phase, and then the second is the perineal phase, or the propulsive and the expulsive phase. So for the pelvic phase is before once the head hits is where the head descends maximally to the pelvic floor and then is expelled. So that may last for different times in different patients, depending on the parity. So for a primigravida who is in her first delivery, that pelvic phase and the propulsive phase can last at least 2 hours. Why for a woman who has delivered before, that usually lasts about an hour. Now, if this patient is on epidural anesthesia, that increases to 2 hours to 3 hours in a primigravida and 2 hours in a multipara. So usually, once a woman is lasting that long in the second stage, it's usually an indication to intervene. And some of the things that can be done for this patient at this stage is, assisted vaginal delivery with either a ventouse or vacuum, the use of a forceps. So, if also there is fetal distress in second stage of labor, a ventouse or or forceps can also be done, or the patient can even go in for cesarean section. So, some patients also get to have pelvic disproportions or even obstructed labor in the second stage of labor. So, for those patients, they go on to have cesarean section. However, if the baby is already dead, there could be consideration for destructive vaginal surgeries, which include craniotomy, cladotomy, and all the rest of them, including even things that can be done to the mother, like separation of the PCO of the pubic symphysis. So that is what the second stage is. Ideally, the monitoring of the fetal heart rate in the second stage, as I said, in low risk patient can monitor for 15 minutes, but in high risk patient, monitoring should be every 5 minutes until that woman delivers. So vaginal examination, after the first one is done, it doesn't have to be repeated until the patient is having the urge to bear down. So that is what is done in the second stage. For the third stage of labor is the period from the delivery of the baby till the delivery of the placenta. Now, there is usually active management of the third stage of labor is what is actually advocated by the WHO, and is still being advocated till now. So the first thing to be done is immediately after delivery of the baby, an oxytocin, in this case, oxytocin, is the most commonly used. 10 international units usually given either as IV or IM for this patient. And then one of the new components in these in the active management of the third stage of labor, which I think should have started appearing in your exams by now, is the early cord clamping. Sorry, delayed cord clamping, not early. Delayed cord clamping is cord clamping that is done within 60 to 180 minutes. That is 1 to 3 minutes. But time is given before the cord is clamped, usually within 3 minutes. Now, that is part of the active management of the third stage of labor. And then the last thing that is done is the control cord traction. However, what we knew before, or what was done before, is that the delayed cord clamping was not a part of the active management of third stage. And what was there was uterine massage. Uterine massage is not really advocated as a measure of the third stage anymore. So I don't know if that has already started occurring in your exams, but that is the current stand of the active management of third stage of labor. Now, there is an arbitrary time on which a placenta is expected to be delivered, and that arbitrary time is 30 minutes. So if the placenta has not delivered within 30 minutes or by 30 minutes, after 30 minutes, usually the placenta is said to be retained. And a retained placenta, should be delivered. The ultimate way to deliver is usually by manual removal in theater. Now, depending on the cause of the retained placenta, because a morbidly adherent placenta can also refuse to be delivered. Now, if a morbidly adherent placenta refuses,
Shifubong,
yes,
please, could you on your video again, please?
my video is actually on. Okay, are you seeing me now?
Yes, I can see you now.
I've actually
Okay.
been on since. So, so as I said, so for delayed placenta, retained placenta, as I said, can be delivered by manual removal of placenta. However, if a morbid placenta refuses to deliver, it can also a point where some people have said is removed as piecemeal, and it can even be left in situ. And methotrexate is now given to the patient to see if the placenta can be resolved. In some instances, a retained placenta with morbidly adherent placenta can eventually lead to removal of the uterus, that is hysterectomy for some patients. So there is also an entity called the fourth stage of labor. Now, this is just arbitrary and is actually advocated by the Americans, by the American College of Obstetrics and Gynecologists. This fourth stage is just the first hour following delivery of the placenta. So they believe that a woman is still having a lot of issues at that point and should be monitored actively for the first hour following delivery of the placenta. So that is why they came up with the term of the fourth stage of labor, which some people have also, agreed with them. So this is just a brief on labor and the management in labor. If you have any question, I think I'll just stop here and take some questions. We'll discuss other aspects of O&G subsequently. Thank you very much.
Thank you, Chief Ubong. What an enlightening lecture. So please, those who have questions could kindly ask them now while our chief still remains.
Good afternoon, sir. What I wanted to ask was about the delayed cord clamping and the control cord clamping in the active management of the third stage of labor. I didn't quite understand the explanation. If you please just quickly again.
Okay, thank you very much. So, what I said is there is a term called delayed cord clamping, and then control cord traction, not control cord clamping. So, delayed cord clamping is usually when the cord is, is clamped. Usually, you double clamp the cord on the maternal and the fetal side, and then you cut in between. So, it has been advocated that since a lot of the baby's blood is in the placenta, you should allow some time for the blood to return to the baby, and the time that has been said to be allowed should be at least within after 60 minutes, but before 3 minutes. So that is what is delayed cord clamping, before you clamp the cord and then you cut subsequently. But control cord traction is where you
Sorry, Chief Ubong, do you mean after 60 seconds and before 3 minutes? Because you're saying after 60 minutes.
Seconds and 180 seconds is when the cord should be clamped. It should not be clamped before 60 seconds and should not also be clamped after 180 seconds. So it should be clamped within that time. So that's what is referred to as delayed cord clamping, except in certain patients. And those patients include patients with RVD and patients with hepatitis. So you don't want, prolonged contact in the morning.
Sorry, patients with RVD and patients with what, please?
Patient with hepatitis B, C, cannot also be allowed to, because blood mixes during delivery. You want to minimize that was in those sets of patients. Do you understand?
Yes, thank you, sir.
Yes, sir.
Yes, sir. So, you mentioned something about methotrexate in the last period of the lecture.
Sorry, please can you speak up?
You mentioned something about methotrexate as a treatment, but I didn't really get that aspect in the lecture.
Okay, that was when I was talking about management of a retained placenta. As I said, one of the things that can be done is that this placenta can be left in situ. If you have removed the bits and then there are still some left and the woman is not bleeding, you can leave it in situ and then give this woman methotrexate. So methotrexate could help the body, or promotes the body's ability to resorb the placenta.
Thank you, sir.
So did you get that?
Yes, thank you. I did. Thank you.
Okay, more questions? You should ask all the questions because start looking at the pathographs, to solve the part. I'll draw some and project it on the group, and then we can solve the questions together. I think that would be more interactive.
Chief Ubong, we sincerely appreciate you so much for this time. Even though we know you're on call from your busy schedule, you still found time to come and educate us. Thank you very much. We can always let God bless you because we don't have money to give to you. So thank you very much. We do sincerely appreciate. So can we just tell him a thank you before we continue the next lecture?
Thank you
Please
so
let's
much.
thank him.
All right.
Thank
Thank
you, sir.
Thank you, guys.
Thanks, everyone.
Thank you, sir.
All right, you're welcome. Thank you.